If your child has autism, please watch this video. Some autism parents are told some version of this early on. Your child will probably never speak. Your child may never learn. Your child may always be like this. What almost no one tells you is that sometimes the brain is not broken. Sometimes it is starving. There is a condition called cerebral folate deficiency that quietly reshapes what we think we know about autism, development, intelligence, and prognosis. It is not rare in the sense of being unbelievable. It is rare in the sense that most doctors are never trained to look for it. When it is missed, children are often labeled with severe autism, intellectual disability, or global developmental delay. When it is identified and treated, some of those same children gain language, attention, regulation, and connection that once felt completely out of reach. This video explains what cerebral folate deficiency is, how it shows up in real children, how it is diagnosed, how it is treated, and why it can so closely mimic autism. Most importantly, it explains why awareness matters, especially for children who are labeled severe, nonverbal, or profoundly delayed. Folate is a B vitamin that plays a critical role in brain development. It is involved in DNA synthesis, neurotransmitter production, energy metabolism, and the building and maintenance of neural connections. During pregnancy and early childhood, folate availability helps determine how the brain grows, wires itself, and communicates internally. Cerebral folate deficiency, often called CFD, occurs when there is not enough folate available in the central nervous system, even when blood folate levels are normal. This detail is crucial. Many children with CFD eat adequately. Many take vitamins. Many show normal folate levels on routine blood work, and yet their brains are still deficient. The reason is transport. The brain does not receive folate directly from food. Folate must cross the blood-brain barrier through specialized transport systems. One of the most important of these is the folate receptor alpha. In many children with cerebral folate deficiency, this transport system does not function properly. In some cases, the folate receptor itself is genetically impaired. In other cases, the immune system produces antibodies that block the receptor and prevent folate from entering the brain. In both situations, the result is the same. The body may have enough folate, but the brain does not. This creates a very specific kind of neurological stress. On the outside, the child may appear nourished. On paper, lab results may look normal, but inside the brain, critical biochemical pathways are under-resourced. The brain is trying to grow, regulate, and communicate without one of the nutrients it relies on to do those things. The developing brain is extraordinarily sensitive to metabolic disruptions. Small biochemical imbalances can have outsized effects. Folate is involved in methylation pathways that regulate gene expression. It supports neurotransmitter balance, including systems that affect mood, attention, and motivation. It plays a role in mitochondrial function, which determines how much energy neurons have available. It also supports myelination, the insulation around nerve fibers that allows signals to travel efficiently. When folate is missing where it is needed most, the brain adapts, it compensates. And those adaptations often look behavioral. This is why cerebral folate deficiency does not present like a simple vitamin deficiency. It presents like a neurodevelopmental condition. Children with CFD are not lazy, they are not unmotivated. They are not choosing not to engage. Their brains are attempting to function under biochemical constraints that limit processing speed, regulation, and integration. Cerebral folate deficiency does not look the same in every child. There is a wide spectrum of presentation, which is one reason it is overlooked. But there are patterns that appear again and again. Many children with CFD develop typically at first. They may meet early milestones. They may smile, babble, make eye contact, and respond socially. Then, often between 6 months and 3 years of age, progress slows or stops. Some children lose skills they once had, others plateau and fail to gain new ones. Speech delay is extremely common. Some children remain nonverbal. Others speak in a limited, inconsistent, or effortful way. Receptive language may be stronger than expressive language, or both may be impaired. A child may understand far more than they can express, or they may struggle with both. Motor symptoms are also common. These can include low muscle tone, delayed walking, clumsiness, poor coordination, or unusual gait patterns. Some children appear physically weak or fatigue easily. Others struggle with fine motor tasks like feeding or writing. Behavioral and emotional regulation challenges are frequently present. Children may be highly irritable, prone to intense meltdowns, or unable to tolerate sensory input such as noise, light, touch, or movement. Transitions may feel impossible. Minor stressors may trigger disproportionate reactions. Sleep disturbances are very common and can be severe. Difficulty falling asleep, frequent night waking, or very early waking can all occur. Poor sleep further worsens neurological regulation. Cognitive symptoms may include poor attention, slow processing, difficulty learning new information, or uneven development. A child may show strong abilities in one area and profound struggles in another. This uneven profile is often confusing to clinicians and educators. Seizures can occur in some cases, particularly when cerebral folate deficiency is untreated. Autistic features are extremely common. These may include limited eye contact, reduced joint attention, repetitive movements, sensory sensitivities, rigidity, difficulty with social communication, and challenges with reciprocal interaction. When these features cluster together, especially in the presence of early regression or severe language impairment, children are often diagnosed with autism. Many are labeled level 3. Autism, however, is a behavioral diagnosis. It describes how a child communicates, interacts, and behaves. It does not explain why. Cerebral folate deficiency creates neurological conditions that produce behaviors indistinguishable from autism because it disrupts the same systems that underlie social communication, sensory processing, and regulation. When the brain lacks folate, neurotransmitter systems are affected. Dopamine, serotonin, and glutamate balance may be altered. This impacts attention, motivation, emotional regulation, and social engagement. Mitochondrial stress may occur, reducing the energy available to neurons. This can lead to shutdowns, withdrawal, reduced responsiveness, and cognitive fatigue. From the outside, this can look like disinterest or detachment. Myelination may be impaired, slowing communication between brain regions. This affects processing speed and integration of sensory and social information. The child may need more time, more repetition, and more support to respond. The result is a child who appears autistic, not because of a fixed neurodevelopmental identity, but because their brain chemistry is compromised. This does not mean autism is not real. Autism is real, but autism is a description, not a cause. In some children, the cause includes treatable metabolic conditions like cerebral folate deficiency. Diagnosing cerebral folate deficiency requires intentional investigation. It does not appear on routine developmental screenings. It is not detected through standard blood tests alone. The most definitive diagnostic test measures levels of 5-methyltetrahydrofolate in cerebrospinal fluid obtained through a lumbar puncture. In cerebral folate deficiency, these levels are low even when blood folate is normal. Because lumbar puncture is invasive, it is not always the first step. Another critical test is a blood test for folate receptor alpha autoantibodies. These antibodies can block folate transport into the brain. Their presence strongly supports a diagnosis of CFD and can guide treatment decisions. Some clinicians also consider response to treatment as part of the diagnostic picture. When a child shows meaningful improvement after starting appropriate therapy, this can support the diagnosis even if invasive testing was not performed. Neuroimaging may be normal or show nonspecific findings. EEG may show abnormalities if seizures are present. Genetic testing may identify underlying transport defects in some children. The most important diagnostic factor is awareness. Without suspicion, cerebral folate deficiency is rarely identified. Treatment for cerebral folate deficiency does not involve standard folic acid. This distinction matters. The primary treatment is folinic acid, also known as leucovorin. Folinic acid is a bioactive form of folate that can bypass some of the transport barriers that prevent folate from entering the brain. It uses alternative pathways to cross the blood-brain barrier. Doses used in treatment are therapeutic, not nutritional. They are significantly higher than what is found in standard supplements and must be prescribed and monitored by a knowledgeable physician. Treatment plans are individualized. Dosage, timing, and monitoring depend on the child's age, weight, severity of symptoms, and response to treatment. In children with folate receptor antibodies, Dietary changes such as eliminating cow milk proteins may be recommended. In some children, proteins in cow milk stimulate antibody production, further blocking folate transport. Treatment is typically long-term. Improvements may occur gradually. Some changes are subtle, others are dramatic. Progress is often uneven, with gains in one area appearing before others. Not every child responds in the same way. Outcomes depend on age at treatment, duration of untreated deficiency, severity, and individual biology. Documented improvements in treated children include increased speech and communication, improved attention and engagement, better motor coordination, improved sleep, reduced irritability, decreased seizure activity, and enhanced social responsiveness. Some children who were previously nonverbal begin using words or communication devices more effectively. Others show improved understanding, connection, and emotional presence, even if speech remains limited. Improvement does not mean a child becomes neurotypical. It means the brain is better supported. It means the child has access to a resource they were missing. For families who were told nothing could help, even small changes can profoundly alter daily life. Cerebral folate deficiency is not a miracle cure. It does not erase disability, but it does change the question. Instead of asking what is wrong with this child, it asks what this child may be missing. When CFD is overlooked, children may spend years in therapies focused only on behavior without addressing underlying biology. Parents may be told to accept severe limitations without being offered deeper investigation. When CFD is identified, the narrative shifts from resignation to curiosity, from managing symptoms to supporting systems. If you are parenting a child labeled severely autistic, nonverbal, or intellectually disabled, this is not about false hope. It is about informed hope. Not every autistic child has cerebral folate deficiency, but some do. And for those children, awareness can change everything. Brains adapt to scarcity. They survive, they compensate, they reorganize. Sometimes what looks permanent is a signal of unmet need. Sometimes the most compassionate thing we can do is ask whether the brain has what it needs to do its best.